Restarting. Dr. Ingrid Friberg is a Johns Hopkins Bloomberg School of Public Health trained epidemiologist at the works at the Tacoma-Pierce County Health Department. We're very lucky to have her. She has spent more than 20 years working in maternal child health, global health, and health information. She has been part of an analytic team supporting the World Midwifery Report and the Lancet Ending Preventable Stillbirth series. She was also on the e-registry team for improved quality of antenatal care. At the health department, she is a senior epidemiologist in assessment, evaluation, and epidemiology, providing analytic and subject matter expertise on a broad range of domains, including mortality, breastfeeding, child deaths, youth firearm violence, and other injuries. Please join me in welcoming Dr. Friberg.
Didn't know you were going to read that. So, let's see here. Let's start with making sure this all works. There we go. Okay. Gotta move myself. I'm moving this. Because I can't function if I can't see both you guys and the slides. That's what I need to be able to do. So, thank you guys all for coming today. I love talking about maternal and child health, which is what you will see throughout this entire presentation. And since you already introduced me, I don't really need to introduce myself anymore. What I want to talk about today is just giving you a little bit of the scope of what I'm talking about so we can make sure that we're all talking about the same thing. And then I'm going to talk about 3 key areas within this pregnancy and postpartum period, specifically touching on prenatal care coverage, birth outcomes, perinatal mental health, and then I'm going to throw in a few little nuggets of information that will hopefully be interesting to everybody. So I can't figure out if it's working. Is that right? Okay. So the perinatal period. Well, we know that traditionally the perinatal period talks about 22 weeks through 7 days postpartum. But I am, for this presentation, expanding that to really cover the entire time period from conception through 1 year of age. Because I think it really fits very well with the people who are here at this conference, and it makes a lot of sense. What's interesting is when I was looking up definitions for perinatal mental health, they say anything that happens during pregnancy and through 1 year of age. So you're like, well, why do we have 2 different definitions? But that's not my problem. I'm not that level of person to decide that. So I see this period as being anchored by 3 different time points. We have conception, we have childbirth, and then we have 1 year of age. So those 3 different time periods coalesce around everything that we're talking about. Within there, we also have health care that's provided to somebody. We have prenatal care, and then after childbirth, we have the separate pediatric care and postpartum care systems. But don't forget, we have to consider all of the health care that a person has received beforehand during the pre-pregnancy period. These are not isolated little pockets. It is a continuum there. We can also look at the conditions that occur, the conditions and complications that occur during pregnancy as being pregnancy-related, as well as the postpartum conditions and complications. But once again, we can't forget about what happens beforehand, because all of that is integral for the experience that a person has during pregnancy. And I just want to remember that all of these different conditions and illnesses and cases and situations and healthcare systems all have to work together because the person is the same throughout this entire time period. But once again, we cannot just leave it at just talking about the healthcare system and the conditions, because we also have to consider the social determinants of health, which lead to a lot of these conditions and experiences that a person has. When we look at what they specifically are talking about, they talk about economic stability, education, healthcare access, your neighborhood and where you live and where you are, as well as your social and community context. Throughout the rest of this presentation, I'm going to try to touch upon some of the features of how pregnancy-related care interacts with these social determinants of health. But before I do that, I want to remind you of one last little tiny tidbit. Why are we doing this? We're doing this because we want happy, healthy families and babies. And that is our end goal, is to think about how to make that happen for everybody. When we're thinking about this time period, we can think about all sorts of different impacts. One of them is mortality, which thank goodness is actually quite small in our community. We are very lucky in that way. It's just the tip of the iceberg. But we also have to consider the physical impacts which can occur to a person who's giving birth. They can have near misses and have a hemorrhage that gets solved and they don't die, but then they've got long-term anemia issues. We can have tears, we can have fistulas. If a person experiences diabetes during her pregnancy, they're then at greater risk of having more diabetes at a later point in time. So the experience, the physical experience of pregnancy doesn't end when the baby is born or when the breastfeeding ends. It's a lifelong experience that you're stuck with, whether you want it or not, sadly. And we also need to consider the behavioral health and mental health issues, because those are key as well. You can't just stop with thinking about those physical impacts. You have to think about the mental health of the person who's actually giving birth and their families, as well as the development of the child. So we can have impacts on all of these different levels regarding when a person is pregnant. I'm going to start by just talking about mortality because this is the tip of the iceberg, and as I said, it's relatively small numbers. What I want to point out is that on the left-hand side, we're showing you a little bit about the three main causes of mortality in pregnant people. This comes from the Washington State Maternal Mortality Review Panel and their report for 2014 through 2020. And one of the things you'll notice is that, hey, we've got hemorrhage and infection, which are some of the most common causes that we're really thinking about. But when they combine them all together, they show that behavioral health conditions, such as substance use, depression, and suicide, are actually the #1 cause of mortality in the pregnancy period. Those are for pregnancy-associated deaths. And if we look at ones that are directly being caused by, exacerbated, or due to that pregnancy, we can find that 1/3 of those types of deaths are associated with behavioral health concerns. So behavioral health is a key aspect of the entire pregnancy period. On the right-hand side, we can see that we look at babies 0 to 1 years of age. Yes, I don't have a section for stillbirths. Sorry about that. I should have put that in there as well, but I didn't think about it until just now. I should have. The #1 cause of infant mortality is congenital conditions. The second is actually what they code as this big category called perinatal conditions, conditions during pregnancy. It's a very broad category. So I looked at the ICD-10 codes to try to understand a little bit better what they were talking about because it seemed like a mishmash to me. And what they did was they actually decided that it was categorized in 2 ways. One is clearly maternal complications, such as PROM, hemorrhage, incontinent cervix. All of those are the maternal complications that lead to infant mortality. And then they had a second category where they called it gestational complications. Of course, they also did define this as gestational complications in the absence of any known other cause. So I'm not 100% sure how well these are actually differentiated in the real world, but I wanted to point out that hemorrhage is a factor for both mothers and babies. And of course, SIDS is also important. However, for the purposes of this presentation, I'm actually not going to go into anything with congenital and SIDS because I'm trying to focus on the care provision during childbirth and childcare. And so, just to bring you back to this figure of where we're at, we're going to be talking about prenatal care. Flickers a little bit. So prenatal care during childbirth. Prenatal care during childbirth? No, prenatal care. If we look at the trends in prenatal care, we find that they really haven't changed very much. The green line on the top shows what's going on in Washington State, and we can see that it hovers at about 70% of people who are having an adequate prenatal care. If we look in Pierce County, we see that it's noticeably lower. It was about 58 about 20 years ago, and it's actually had a nice increase, but we're dropped back down to about 63. So in essence, there's been no change in the proportion of pregnant people who are accessing prenatal care during their pregnancy over 20 years. That's difficult. No changes. And when we also want to think about, when we talk about prenatal care, we can't just talk about the contact. Right now, when we talk about coverage, we're saying the percentage of people who receive adequate prenatal care. who get the right care at the time that they need it. But we're not actually talking about did they get the right services during that prenatal care visit. We just say, did they attend that visit? When we look at the World Health Organization's definition of quality of care, they do include the provision of care. Did you get the evidence-based practices? But they also want to make sure that you're having the right experience of care. Effective communication, respect and preservation of dignity, as well as emotional support. All of those are key features of having an appropriate, good quality of care when you are pregnant. You need all of those features. And our indicators, unfortunately, don't do a great job of getting at some of those details. So we're missing something there. We're missing the real experience that a person is going through. But not much I can do about that one today, just to point that out. I also want to talk about access to prenatal care. So this is about who is getting prenatal care at what time, by whom. And let's start out with, the map looks even fuzzier now than it did when I created it. Sorry about that. On this figure, we're showing you the percentage of pregnant people who started their prenatal care during the 2nd and 3rd trimesters. We're not talking about people who never have prenatal care. That is a smaller subset. It's about 5 or 10, and it's relatively intractable as well. But these are the people who attend care. They just start really late. And what we can see is that the eastern half of Pierce County, it is between 15 and 20% of the population that goes late for their prenatal care. On the western half, it's 20 to 25%. Okay, so this says there might be different people there. But when we look in more details about the subpopulations that are living in these areas, we can take a look and get a little bit more granularity. If this particular figure shows us, with the exact same scale as the previous one, the proportion of Black, non-Hispanic pregnant people in Pierce County, and what proportion are getting their prenatal care delayed, late, 2nd and 3rd trimester. The only sections that are about the same are right here, 15 to 20%. And then we have down here and in here, we have a few areas where it is 20 to 25%. But then we can go look and see large swaths of our community, 25 to 30% of Black, African American, non-Hispanic, pregnant people had delayed prenatal care. So there's this interaction between where you live and who you are and whether or not you're accessing care. It's not just a monolith of what's going on in our community. And just to make it even more obvious, some of these disparities, let me show you one of the most egregious maps that I have. This is the American Indian Alaska Native population in Pierce County. There is no area where this population gets 15 to 20% of their population having a late prenatal care. There's only a few spaces that we have 20 to 25%. And then we have few spaces that are 25 to 30, large populations that are 35 to 40, and areas where more than 40% of pregnant women are going late for their prenatal care, which means that they don't have as many opportunities to have their complications diagnosed. Not as many opportunities to get somebody to listen to you when you're having a really rough day, because pregnancy isn't easy by any stretch. So we really need to think about that interaction. Now I'm going to talk a little bit more about those pregnancy conditions and complications that can get identified during the prenatal period. The most common ones that we're talking about are hypertension and diabetes, which are very common conditions during pregnancy. And then we look at prematurity and low birth weight, which are some of the most common outcomes that we're often talking about. On this slide, it's a little bit busy, but I want to show you that the dotted lines are Washington State and the solid lines are Pierce County. So they're just showing us that everything that we're seeing in Pierce County isn't just Pierce County, it's the rest of the state as well. The top two lines are showing in green and orange gestational hypertension and gestational diabetes, while the bottom lines, which are in blue and purple, are showing pre-pregnancy diabetes and pre-pregnancy hypertension. The key thing to note from this, since it's kind of complicated, is just everything is getting worse. And some of the worst increases, or largest increases, are in gestational diabetes, going from about 3% to about 11%, tripling over the past 20 years. When we look at the birth outcomes, though, which we would assume would be somewhat related, we see that there are not a lot of differences there. They're pretty flat. There's pretty unchanged in both Pierce County and Washington State. Not a lot of change. And I wonder why that is. Well, one of the reasons might be more visible in this figure. What we can see, without even looking at these numbers, is that the proportion of people who have a high school education or less, who are giving birth, has decreased in number over time. When we look at the people who have a postgraduate degree or more who are giving birth over time, those are increasing. So the underlying population who's giving birth is changing in our community. And when we look at the different health outcomes for prematurity based on the person's education, what we see is that people with a high school degree or less, their probability of having a premature birth has increased over time. While there's been almost no change in people with a college degree or college-educated partial degree or completed, where there's been a reduction among those who have a postgraduate degree. So your educational experience is highly correlated with what's going on in terms of your pregnancy outcomes. Remember, these are one of the social determinants of health that helps you to understand why things you're experiencing are the way they are. The next section is going to talk a little bit about perinatal mental health. We can't have these conversations without really considering what's going on in Pierce County and elsewhere in perinatal mental health. And note that it covers not just the pregnancy period, but it incorporates pre-pregnancy behavioral health issues or concerns as well. It includes depression, anxiety, psychosis, substance use, all of those. We talk about those. We don't talk about parental suicide as much. And knowing that the experience of the quality of life, parenting, and relationships is really affected by what your mental health experience is during this time period. I didn't put stress on there, but Jack's already mentioned how stressful being a parent is, which also changes your experience. And what we know from the pregnancy risk factor, I can never remember what PRAM stands for. It's a horrible piece that I have here. I don't remember.
Pregnancy Risk Assessment
Monitoring System. I wrote it down because I knew that I was going to forget it. I work with the data all the time, but I don't actually look at it. The name, spell the name out all the time. Anyway, when we looked at the PRAMS data, this Pregnancy Risk Assessment Monitoring System, where they asked people, have you had postpartum depression? It wasn't diagnosed by a doctor, but just did you experience this? What they found was that across the entire United States, about 13% of the population said, yes, I have. But when you dig down a little bit deeper, you realize that there are really huge disparities as to who is experiencing postpartum depression. The white population, about 11%. The Hispanic population, 12%. And then you see some very large differences when you look at your American Indian, Alaska Native, Asian Pacific Islander, and Black non-Hispanic populations. They're almost twice as likely to have somebody in their community experiencing postpartum depression. And no, we didn't talk about the anxiety, the stresses, the poor relationships, the experiences that you have. This is just one little piece of information. And in Pierce County, this trend is exactly the same in terms of the levels as well as the disparities that we're seeing. But once again, I really want to think about some of those social determinants of health. What happens if you have a different income? Well, it makes a huge difference in your experience of postpartum depression. I don't think anybody's going to be surprised by these numbers. But what we can see is in Pierce County, between 2016 and 2022, the probability that a person would report postpartum depression is 23% for those who make less than $24,000 a year. Whereas it's less than 7% for people who make more than $85,000. I think that's the math. It's a threefold difference. You're 3 times more likely to experience postpartum depression, or to feel like you have experienced postpartum depression, which is the same thing, if you have less money. So your social experience, your experience in the world, your social determinants really do affect what you are experiencing during that time when you're bonding with your child. So I know that's really depressing, isn't it? But let me tell you some other nuggets of truth. And these are tiny little pieces of information that you can just think about as you're thinking about everything that gets talked about today in terms of the experiences and disparities. And I just thought they were interesting. And one of them just popped into my inbox a few weeks ago. Or somebody asked me a question and we looked it up and found the answer. But this one is interesting. Congenital syphilis. Has anybody been hearing about congenital syphilis out there? Yeah. Lots of people have been talking about it. Well, this shows us that nationally, because this is from the MMWR, we can see that there's been a ginormous increase. It's almost a 10-fold increase in the number of babies that are born with congenital syphilis in our country. 10-fold for a disease that we almost have cured. And the fact is that all you need is prenatal care screening and treatment. That's all you need to prevent this particular outcome in these populations. In Pierce County, our numbers aren't quite so large, but what we have found is that between 2021 and 2024, there's been a 3 to 5 time increase in the number of pregnant people who are experiencing syphilis. And this is folding over, and you can see the same exact outcomes in our babies who are experiencing congenital syphilis. And it's been a shift where prior to 2020, almost every baby was getting treated effectively, identified and treated. Not so anymore. A dramatic shift since 2020. Another question that I have is about neonatal withdrawal syndrome. So it's a small factor, it's not huge. Between 9 and 34 babies are being hospitalized each year where it's being coded as neonatal withdrawal. Not a huge number. I sadly don't have the numbers for 2022 or 2023 yet. But what we can see is that a lot of people might have assumed that 2021 might be the highest because of all the opioids in our community. But it was actually 2018 where we saw the largest number of neonatal withdrawal hospitalizations. And our lowest number was actually in 2020, when everything else was going haywire in our community, to be blunt. So I think it's really important to just think about the fact that we need to know what's going on, not make some assumptions. Oh, I assume that it's getting worse because I know that that's going on. Let's take a look. Take that step back and look at the data and just see what the reality is, because it might be different. So what is the status of Pierce County? Well, some things are going fantastically. Our reduction in our infant mortality and maternal mortality over the past 20 years is fantastic. This is good news. We love it. The percentage of birthing parents who are smokers, as well as the percent who are under 18 years of age, has also dropped, both of them, leaving us with a community that's more able to take care of the babies that are being born, which is wonderful. On the other hand, we have no change in our low birth weights and minimal change in our adequate prenatal care. So 20 years, no change, these aren't as good. And then of course we have the things that are getting worse, right? We know syphilis has increased, diabetes has increased, hypertension, 3-fold, 4-fold, 5-fold, depending on what you're asking about, 10-fold. So just realizing that it's a mixed bag, and things are getting better, but not everything's getting better. And we don't know who it's getting better for at this point. So in conclusion, things are getting better, worse, and unchanged. And it's complicated, right? You want to say everything's going the same direction, but it's never going to do that. And when you look at those social determinants of health, you can see some of the complexity. And these can help us to identify some subpopulations of our community which might need more support, or where we've had blinders on and we just haven't done anything with it yet. We're like, oh, did that really happen? No, it's not there. But the data shows us that it is going on. And of course, when we look at that intersectionality of social determinants between each other, as well as with race and with other factors that we know are critical, you can even narrow down and focus more heavily on who is really the person in need. Because that's the whole goal, is identifying those populations at greatest risk. And we don't know some of those, which is one of the reasons why we have prenatal care for everybody. but it's also helping us to focus those improvements and to make the changes in both the quantity and quality of care so that everybody can be that person who has a healthy, happy baby. There we go.
Hey there.
I can stay here.
We have 5 minutes for Q&A. And Chris Laddish has got a microphone, so we'll just move that around the room. So please raise your hand and we'll take time.
Hi. I have a question about prenatal care. You said it's pretty stable. And then you mentioned adequate prenatal care. How would you define adequate prenatal care?
Okay, so the definition, so it's really interesting. So I was going to mention it in this presentation, but I forgot, blah, blah, blah. So this particular adequate prenatal care is actually based on the Kovalchuk Index, which is defined as a combination of when prenatal care was started as well as the number of contacts. So that's the only definition that we have for quote-unquote adequate prenatal care at this point. Yeah, not nearly as interesting as it could have been.
Hello, thank you so much for your awesome presentation. I work in the methadone clinic at the health department. Actually, it's treatment services now because we offer all medications for opioid use disorder. But I'm just wondering, do you know what has attributed to the lower numbers of neonatal abstinence syndrome? Is that changes in the hospitals that they've made with their ESC programs? Maybe women who are more stable on their dose, or do you know what that is from?
No, I have absolutely no idea. I actually just look at the numbers and I rely on people who actually have the experience in the field to tell me what it actually means. So I actually don't know what it's attributed to, but it is a relatively small number, 9 to 34. And I'm also not going to say for sure how well coded all of these are. So there could be, because I'm not a practitioner, just so you know that. So I would say that I have no idea why those different, but when I looked at the data, it goes up, down, up, down, up, down, up, down. So I don't see any trends in that small period of time. So I think it's more about the experience of the pregnant person rather than the health systems based on that small understanding.
Thank you.
You're welcome.
Hello. I'm Andrew Gillette. I'm one of the midwives that works for Multicare, and I'm in the West Pierce group. I just want to say that I didn't know you guys existed. I worked for Multicare this is my 3rd year, and so I was so excited to finally get plugged in, and I think that's probably my peers' experience too. So I'm really excited to see everyone and do connections. Beyond that, I was really curious about one of your slides that was saying, like, we're missing, even for late entry into prenatal care, we're just missing big chunks of people.
So it's more that on this particular graph, what we're seeing here is that I'm only showing those who started the 2nd and 3rd trimester. People who did not get any prenatal care, which is less than 10% of the population, I didn't include in this particular proportion because I wanted to talk about those who are actually accessing care, but clearly not getting the care that they need or hopefully want in order to have a healthy pregnancy.
I was just wondering if you have thoughts or suggestions on where that's being missed or how that's happening and how do we get to those groups?
I think that's a really complicated question, and that's actually one of the reasons why I put together the maps, to really be able to focus that conversation, because I've done some preliminary analyses looking at things like, oh, is it the people who already have babies? Is it different ethnic groups? Is it different this? And there isn't a real pattern there except for these big racial and ethnic groups. And what I think it is it involves more conversations with people to ask them, well, was it because you couldn't get it on time? Was it because I didn't want to go, because I didn't trust it, because last time was useless, because the midwife was nasty? Sorry, not to, yeah. That was not, right? I mean, there are so many different reasons, and the PREAMS data does have asked some of these questions, but once you get down to the smaller and smaller populations, they become slightly unreliable. This is where, like, interviewing people and asking people, like, why didn't you, and what were the barriers, and understanding their experiences in pregnancy is so critical. Because, I wish I had a better answer.
Well, I also was wondering, sorry, I guess I have a lot of questions. I was wondering if these groups also, are they having preventive care before they're showing up in pregnancy, or if they've had like no connection with the healthcare systems yet, and so they don't know?
That's a really good question. I actually don't know. I think I might be able to get at some of those questions from the CRAMS data, but I know that it's not in the birth certificate data.
Thank you.
You're welcome.
Hi, I'm Cheryl Pickering with the State WIC office, and I chair the National WIC Association's Infant and Maternal Mortality and WIC Committee, and I'm always really interested in maternal mortality. And I was wondering, I heard what you were saying about our Pierce County's rate, but have you taken a look at it by race to see the real difference?
I have not. So one of the things in Pierce County is that our numbers are actually relatively small. And so one person can change the numbers a lot, which is why when we look at the state analysis, which is what I showed for the maternal mortality, was actually the state level analysis. They still had to combine 2014 through 2016,
Right.
or 2014 through 2020 in that analysis. So it's a
Is that the most recent report?
That is the most recent.
Because there, I remember American Indian Alaska Native has the highest maternal mortality rate. And when I do my work on the committee, it's really hard to find statistics or information on American Indian Alaska Native and even Native Hawaiian Pacific Islanders. And that really worries me that we'll forget about those populations and not take care of them.
Exactly, and that's actually one of the reasons. What you didn't hear is sort of the underlying thought process behind these maps. If you look closely, you'll see that the geographies are actually very different on them, because I wanted to be able to show every one of these populations, but I don't have the ability to show them at the same levels. So if you look here, we'll see for this one, there's very large geographies because we have just small numbers. And so figuring out ways to present the data, differential aggregation is the way I think of it, is helpful to make sure that we don't lose sight of those populations.
We're going to take one more question.
Thanks, sir, for being here and presenting. One of the things, I doubt that you would have an answer for this, but as far as infant mortality, I just want to call out that at some point we need to measure infant mortality to lactation rates and the intersection of that, especially as it talks about the prenatal care, right? Like you go into more prenatal care, you hear more about breastfeeding and the benefits, so just want to call that out.
No, I just want to say that's a really good question. One of the big problems, though, is small numbers and trying to get at good information on breastfeeding. No offense, but it really drives me crazy because I have 4 different sources. In another presentation, I showed the 4 different sources, and the numbers are very different between them. Because one of them is, did you ever initiate? Did you keep initiating? But what are you asking about? How long you breastfed when you send a survey out at 2 months? And that's the last time you contact the person. You don't know what happened. So I agree with you completely, and I wish I had better data for that one.
Dr. Ingrid Friberg.